Hi there, everyone. My name is Prerak Juthani, second year internal medicine resident at Stanford, and today is part 3 of what I am very excited about, which is the Point-of-Care Ultrasound series. Today's focus is going to be on a different view. If you haven't already watched videos 1 and 2, you'll see that the first portion of the POCUS 101 series was on cardiac views, but specifically it was on the peristernal long axis view and how to get that view and ultimately what you can get from it. And then if you stuck around, there's also the second video, which is part 2, which is a previous video as well, where we talked about how to assess the right ventricle, as well as thinking about the specific signs that you can see on echo that would be indicative of pulmonary embolism or pulmonary hypertension. We also talked a bit about how to get the apical 4 view in that video. Today's video is part 3, and I think it is the most relevant when you have a patient with hypotension because this view will allow you to look at the heart and also look at the main vessels that lead to the heart. Specifically, I'm talking to you about this inferior vena cava, and the reason why the inferior vena cava is very important is that it is where every single drop of blood that eventually gets propagated out to your body, brain, and even your lungs has to go through. And so what that means is most of the preload comes through the inferior vena cava, and it also comes through the superior vena cava. And so as long as you can see both of them joining into the right atrium, you'll get a very good idea of just how much fluid a patient can have on you. And so today's video is going to be about the subcostal 4-chamber view, and this view is very important because, as the name implies, it's subcostal. So you can see that the costal margin. The way I often like to think about it is the Sub-Xiphoid view, and the Sub-Xiphoid view helps me because it tells me to remind myself to look for the xiphoid process. And once I find the xiphoid process on my patient, I then use the phase array probe, which we went over in part 1 of the series, the different types of probes, and I basically stick the probe downwards with the indicator facing the patient's left. And you'll see that if you do this, you should be able to come across a view just like this that actually then shows you the heart looking at it from an inferior angle. So you're almost looking up at the heart. And if you angle upward, you'll be able to see the different nuances and the different chambers that are in the heart. The way that you can orient yourself is to always remember that the right atrium is going to be the most anterior portion of the heart. The right side of the heart is anterior to the left side of the heart. And so in this perspective, when you're going from this and looking upwards from the xiphoid process, you'll see that you'll actually have the right atrium and the right ventricle anterior to the left atrium and the left ventricle. And if you do that, you can now again get a very good 4-chamber view. This can be particularly good because you can again still see the pericardium on the outside, and you can assess for tamponade, and you can also assess for pericardial effusion. It's not the best, but you can compare this view to your apical 4-chamber view as well as your peristernal long axis view and see if you do have signs of a pericardial effusion that you may not have seen on other views. Once you get this view, the really great part is once you have this view, you then rotate the probe 90 degrees so that the probe marker is facing to the patient's head. And if you then do that, you'll be able to see the inferior vena cava emptying out into the right atrium. It's very important to do this well because sometimes people will accidentally rotate it a bit too drastically and instead see the aorta. So the way you know that you have the inferior vena cava is that it should be pushing up right against the liver, and you should be able to see the hepatic vein, which is where all of the venous blood flow from the liver will then join with the inferior vena cava. The other way you can also make sure you're looking at the inferior vena cava is that you're actually going to be able to see the right atrium as well. And the inferior vena cava is very important because, as I said, it's going to now allow us to get a good volume assessment on our patient. The reason why this is helpful is most of the time when we do volume assessments and we try to see if a patient is fluid up or fluid down, usually we're looking at their physical exam. Do they have an elevated JVD? Do they actually have lower extremity edema? Do they have crackles in their lungs? And sometimes while that can be helpful, it's also really amazing to be able to look at a blood vessel and use that as a proxy for just how much fluid someone may have on their body. So if you actually get into this view and you see the inferior vena cava emptying into the right atrium, you can actually measure it. So on an ultrasound, you can pause the image and you can measure. I usually like to measure, and the best way to do this is to measure about 3 centimeters from where the inferior vena cava meets the right atrium. So 3 centimeters this way to the left, and you want to measure left to right. Top to bottom in this cross section. And when you measure the size of the inferior vena cava, you'll see why that's so important. If the inferior vena cava is really, really massive, like let's say it's 3 centimeters, and usually when someone takes a deep breath in, they decrease the intrathoracic pressure because your lungs are expanding, and usually the IVC should compress. But if it doesn't compress, that tells you that the patient is so fluid up that their IVC is plump, and it also is not varying with respiratory variation. And so I like to use that as a way to think, okay, someone may just have a very high central venous pressure, or they're fluidly volume up, and they might benefit from some diuresis. A normal central venous pressure or right atrial pressure is usually between like 5 to 10, if not a little bit more. I usually use this as a proxy for right atrial pressure. Usually right atrial pressure is not exactly the same as central venous pressure, but if someone has a very plethoric IVC and it doesn't collapse much, I use that to say they have a very elevated right atrial pressure, which again is normal is around 5 to 10. If someone has a very small IVC and you'll see that it's varying a lot, that tells me that there actually might be fluid down and that they might actually benefit from some small amounts of fluid. So then I say, okay, maybe we bolus them 500 cc's of LR and see if they get better. But let's say their IVC is super small, but it's not collapsed. Let's say their IVC is less than 2.1 centimeters and it's not collapsing, or it's more than 2.1 centimeters, but it is collapsing. And what I mean by collapse is usually when someone takes a deep breath in, the IVC should shrink about 50%. If it doesn't shrink by about 50%, that's usually what I refer to as not collapsing. So if the IVC is less than 2.1 centimeters and it's not collapsing, or if the IVC is greater than 2.1 centimeters, but it is collapsing 50%, I usually use both of those to imply that the right atrial pressure is about normal. One, because you're getting good respiratory variation, and two, because sometimes the size is just normal. So that's to kind of review. This view is going to allow you to look at the IVC, which can then get you a very good understanding of what exactly the right atrial pressure is. It's not perfect. Obviously, you want to correlate this with your physical exam. But as I said, the beautiful part about point-of-care ultrasound is that you should never be using it in a silo. But it's just one extra data point that you can add to your overall toolkit to make you a bit more confident about the decisions that you're making. So if you look at the IVC and you see that it's small and you see that there's a lot of respiratory variation, that patient may have a mildly decreased right atrial pressure and may benefit from fluids. If you see that they fall in this intermediate category where their IVC is less than 2.1 centimeters without respiratory variation, or more than 2.1 centimeters with more than 50% collapse on respiratory variation, then their right atrial pressure is between 3 to 8, and I wouldn't worry too much about that. And the last one is if they have a very plump IVC, like huge, more than 2.1 centimeters, and it's not doing any respiratory variation at all, they likely are volume up, and they may benefit from diuresis. So this is kind of the beauty of the cardiac view of this. And again, you can actually use this to then combine with your overall understanding of different types of shock. And when you do that, you'll be able to see exactly how you can kind of piece everything together. So let's say you're worried about someone who could have a distributive component of shock. Distributive means when you have massive vasodilation, you could be septic. And in this case, you can actually then look at your ejection fraction, right, through EPSS that we talked about in our first video. You can even look at your IVC. And you'll see that if the ejection fraction looked okay and the IVC was collapsible, and you think that it's a distributed type of shock, there you go. Now you actually have more evidence to support your claim. Let's say you think someone might be bleeding, or maybe you think their volume down. You'll see that their ejection fraction is probably going to be okay, but the IVC is going to be super collapsible. Let's say you think someone has cardiogenic shock, which means the heart is just not pumping that well. Well, first of all, you should see a low ejection fraction on your EPSS on the parasternal long axis view, but your IVC should also be non-compressible. And so again, these are all really fascinating things that you can put together and ultimately also use to help with your clinical reasoning. So hope you enjoyed this video. I thought this video deserved its own topic, primarily because the sub-xiphoid view is one of the most important views. It can be tough to get, but you usually can just go right below the xiphoid process, push downward and upward to get the view of the heart from the inferior process, and then rotate it 90 degrees to get the IVC into view. And then once you have the IVC, you're going to be really moving. You're going to be making good decisions and hopefully ultimately helping create more appropriate patient care. If you like this video, please drop a like, comment, share, and subscribe. And I'll see you all in the next one. Really means a lot. Peace.